good evening, everybody. Hope you're keeping well. And thank you for sparing time today. So I'm just going to introduce myself and then I'm going to introduce the speakers as well. Okay, so my name is Saira. I'm one of the GPs in Nottingham, currently working in Mary Potter Centre, and I'm a GP associate for Nottinghamshire Alliance Training Hub, NATH, who are presenting you this event today. So thank you very much for coming. I will introduce my speakers and then we'll talk about a bit about, if you could do that before, actually, just before I introduce them. Please make this session as interactive as possible. We're here to help you learn. And both the speakers are very happy to be interrupted at any time for any questions. Please use chat box as well. I'll keep an eye on the chat box. And ideally, we do like people to turn their cameras on if that's okay. You are being recorded because our session does go on to the NATH YouTube sort of channel. But if you're not happy to be recorded or there's any personal reasons, I understand. But please do ideally like to see faces, and also it gives you an opportunity to network amongst yourselves as well. So, okay, without further delay, I'll introduce it's Mr. Andrew Batchelder, who is a consultant vascular surgeon at NUH primarily, but also covers SFH Hospital as well. So most of the Nottinghamshire, and is also a deputy head of service. Thank you very much for coming today and and talking to us about vascular surgery today. And also I'm going to introduce at this point Bryony Webb, who is the lead vascular nurse for NUH, and they will both be talking to us about vascular surgery today. So I think I would let them carry on. Is there any problem? So I hope people are familiar with Zoom. Again, if you're not, please use the chat. The chat function is at if you press more, which is the 3 dots on the top, you can go to the chat box and you can put any questions out there. Any questions really. Do not worry about asking, whether they're, don't feel uncomfortable asking them essentially. Okay, shall we start then?
Yeah, great. Hopefully everyone can see that. Is that projecting okay?
Yeah.
So thanks, Saira. And as Saira said, please feel free to chip in. The aim of this hopefully is to maybe fill in some gaps that people have or reinforce knowledge that already exists. But hopefully it will be useful, but do feel free to ask questions. So we're going to spend the next few minutes talking about lower limb vascular issues, and I guess the aim of this session, which I think has already been highlighted to you, is hopefully to talk a little bit about lower limb peripheral arterial disease, particularly thinking about some of the features of chronic limb threatening ischemia, and I'll talk about what we mean by the term chronic limb threatening ischemia. Also to talk about some sequins that you may or may not be aware of. There's a sequin around chronic limb threatening ischemia and some of its implications. And then the second half is talking a bit about venous leg ulcers and sort of the management of those, both partly within the context of primary care, but also within the context of secondary care. Again, there's a sequin around the management of leg ulcers, and we're going to talk a little bit about some of the implications of that as well. So I thought to kick off, it was useful just to be really clear about some of the terminology we use within vascular surgery. I guess what I kind of want to dismiss, if you like, at the beginning is acute limb ischemia. Acute limb ischemia is pretty rare as a phenomenon, and it typically presents, as you can see, with a white foot. But the 6 Ps that people hopefully are aware of, which you can see on the screen, they're features of acute limb ischemia. And by that we mean these features must have been there for less than 2 weeks. Often it's a number of hours. Patients can frequently describe exactly what they're doing when these symptoms started. So they'll say, I was partway through Coronation Street and then my foot became really painful and cold. It's not the kind of story where it's been present for weeks. This is an acute phenomenon that's been present just for as I say, less than 2 weeks, but often significantly less than that. If you see this in primary care, which you might do from time to time, although as I say, it is uncommon, then actually this is something that needs secondary care management. So all we'd ask really is that you tell the patient not to have anything more to eat and drink, because quite a few of these patients will end up needing to have surgery of some description. And then actually they need to go to the A&E department at their local unit. Typically that needs to be the A&E department at Queen's. The vascular service doesn't have an on-site out of hours representation at Sherwood Forest hospitals. So actually, if you see these patients, even if you're in the north of the county, it would be helpful to direct them directly to Queen's and authorise the sort of paramedics to do that, so that they go directly to the right unit. It's also really helpful if you can pre-warn our service just with a telephone call to the registrar on call, so that we know to go and pick them up in A&E. What are we going to do with these patients? Well, actually, the vast majority of these patients have IV heparin for two reasons, really. One is it reduces the risk of clot propagation, but secondly, it also has a slight fibrinolytic effect and is also slightly anti-inflammatory, and therefore we know that IV heparin can ameliorate the symptoms in some patients. Almost all of these patients will have some form of imaging. Depending on what time of day it is, that's going to determine what modality we use. So, for example, during the day we have arterial duplex ultrasound scanning available to us. That's not available out of hours. So out of hours, this would be managed with a CT angiogram. And then broadly speaking, the further management will depend on both the nature of the symptoms and the duration. Some patients actually have pretty mild symptoms and can be managed with IV heparin alone, and over time the clot dissipates or collateral vessels form. Alternatively, it's pretty common that these patients will require some form of revascularization. You can see here I've got some pictures relating to an embolectomy, which is perhaps one of our commonest procedures for the management of acute limb ischemia. And that essentially involves the passage of a balloon catheter beyond the clot and then literally dragging the clot back out through a little hole in the artery. Most commonly that's performed through the common femoral artery. Some of those patients will also go on to require fasciotomies if there's been concern about the duration of ischemia. There are other strategies as well in terms of both endovascular and a kind of a mix of endovascular and open strategies. We also know that we see some acute limb ischemia very late, and in those cases, often there's no option for revascularization because the damage is already done. So, for example, if the limb demonstrates fixed mottling, by and large, the necrosis is already well established, and at that point, there is no option for limb salvage. One of the key points to emphasize really is that in acute limb ischemia, it's really important that this is managed urgently. So minutes count here, and really if we're going to operate on these patients, we should be operating on them within the first 2 to 4 hours after symptom onset. But actually the meat of this talk isn't acute limb ischemia, because that's an uncommon phenomenon. What I really want to talk about is the chronic aspect of lower limb peripheral arterial disease. And this represents a spectrum of disease, right from asymptomatic patients through to patients with sort of chronic limb-threatening ischemia. Peripheral arterial disease is very common, and as patients get older, it becomes more common. And we know that from studies involving ABPI measurements, between 10 and 20% of the older population will have peripheral arterial disease. Won't necessarily be symptomatic, but it is incredibly common. The risk factors for peripheral arterial disease are those that you'll be aware of for all forms of arterial disease. So there are modifiable and non-modifiable risk factors. And really the main ones to emphasize are smoking and diabetes, because the vast majority of patients with symptomatic or severe peripheral arterial disease will have either a history of smoking or of diabetes. Why is that relevant? Well, actually, it influences the pattern of disease that we see. And on the diagram on the right aims to demonstrate that. So we know that in diabetes, the greatest burden of disease is in the arteries below the level of the knee. So as you can see here, as you go further down the limb, the extent of arterial disease tends to be highest. For some reason, male patients tend to have less disease within the popliteal artery. I can't really explain why that is. It's an unknown phenomenon, but males tend to have more proximal or more distal disease with sparing of the popliteal artery. Hypertension has a fairly uniform effect throughout the leg, but smoking tends to cause more proximal disease and less disease below the level of the knee. So the pattern of disease is really determined to a certain extent by the causative factors. We frequently consulted with referrals for patients who are coincidentally found to have some manifestation of peripheral arterial disease. They may have had a scan for another reason that demonstrates some wall calcification or stenosis of some description. But in the absence of symptoms, actually this is going to be managed exclusively by managing the modifiable risk factors. One of the most common risk factors is smoking, and actually these patients by and large are going to need referral to the smoking cessation team as long as they consent. These patients need to be encouraged to have regular exercise in line with NICE guidelines, so 30 minutes 5 times a week. And then the other risk factors should be managed as you see here. We know that in terms of managing peripheral arterial disease, antiplatelet therapy with clopidogrel substantially reduces the risk not only of peripheral arterial complications, but also of cardiovascular complications and also of stroke. So the main reason for giving antiplatelets and also statins is not so much modifying the consequent outcomes of peripheral arterial disease, but actually it's to try and save these people from dying from heart attacks and strokes, because the vast majority will die from cardiovascular disease. Another manifestation of peripheral arterial disease that you'll see very commonly within the community setting is intermittent claudication. What do we mean by that as a term? Well, this is exertional pain. So this is pain that's brought on by walking. It's typically in the calf, but may also manifest in the thigh and the buttock. The location of symptoms correlates with the level of disease. So for example, if a patient has calf claudication, then the arterial disease will either be in the superficial femoral artery or the popliteal artery. If a patient manifests with buttock claudication, then the disease is typically either in the internal iliac artery or common iliac artery. And if the patient has thigh claudication, then the disease is typically in the common or external iliac arteries. So actually the history can give you a lot of information so that before the scan that the patient will inevitably have in secondary care, you could almost predict what the pattern of arterial disease will be. Claudication is relieved on rest, and actually it's a useful question to really ask, what does the patient do to get rid of that pain? Do they have to just stop, or do they have to sit down? Do they have to bend forwards? One of the common differentials for claudication is spinal stenosis, and actually spinal stenosis requires a much longer period of rest for the symptoms to get better. So if a patient tells you that it takes 15 minutes, half an hour for the pain to go away, that's unlikely to be intermittent claudication, because actually the perfusion will be back at baseline long before that. This pain should settle certainly within 10 minutes, but often in less than that. Similarly, in spinal stenosis, to get the pain to go away, the easiest way to do that is to increase curvature of the spine by maneuvers such as sitting or bending forwards. You shouldn't need to do that in intermittent claudication. So those are sort of red flags really that maybe something else is going on. It's important to appreciate that actually not all patients with intermittent claudication are going to progress. The vast majority won't. and actually only about 10% will end up developing limb-threatening ischemia. So patients often worry that if this isn't treated, they're going to get worse. It's worth reassuring them that's not the case, because often that's all that they're really looking for. In terms of management is again centered on optimization of modifiable risk factors, as with asymptomatic disease. The other really important aspect of management of intermittent claudication is exercise therapy. Ideally, we would be able to offer a supervised exercise program that's in line with NICE guidelines. Unfortunately, that's not funded locally. So I think what we should be encouraging patients to do is exercise as far as they can, for as long as they can, walking through the pain. It's important they do bring on the pain. And the aim of exercise therapy is to try and develop collateral circulation. What I tend to say to patients is that given the nature of their symptoms, it's suggested that the motorways of the circulation have narrowings or blockages. But actually, as with hold up in traffic, traffic tends to find another way, and so will blood. And actually that flow of blood will tend to divert onto collaterals, which are the A roads and B roads. And over time, those collaterals become better developed. As a consequence, we know that up to 50% of patients can improve their walking distance simply by walking more. So it's really important that we do encourage these patients to stay active and try to walk as far through the pain as they possibly can. In terms of secondary care referral, who might we offer intervention to? Well, I think it's really important that we're clear we don't offer intervention to patients that are still smoking. And the reason for that is that smoking makes people prothrombotic. And we know that a significant portion of patients who have intervention will go on to thrombose and therefore need some form of re-intervention. Re-intervention tends to be far more complex, and actually we may be making these patients worse. So unless a patient has stopped smoking, then we won't offer them intervention for claudication. And then arguably, really, there's not much point referring us patients who are claudicants who continue to smoke, because our advice isn't going to change. It's optimization of risk factors, keep walking and stop smoking. Nevertheless, there are claudicants who have disease that, or symptoms rather, that are very substantially life-limiting. If that's the case, and they have had optimization of risk factors already, and they've had a good go at walking, then we may offer them some form of intervention. Typically that will take the form of an angioplasty, but it may involve more invasive surgery depending on the pattern of disease. So this term chronic limb-threatening ischemia, you may have come across it. It's relatively new. It's perhaps only been around for 2 or 3 years. There's lots of confusing nomenclature that's used in vascular surgery. Perhaps some of you will be more familiar with the term critical limb ischemia. And essentially, this is the same as critical limb ischemia, but is the more up-to-date term. And the reason that we have changed that term really as a specialty is that critical doesn't give any feeling of time frames. Everyone knows to a certain extent what acute means. Acute means less than 2 weeks. What does critical mean? I don't know. Is it acute? Is it chronic? Is it something in between? So actually, the terminology was changed to reflect the fact that this is a disease process that's been present for a longer period of time. Symptoms have to have been present for a minimum of 2 weeks to tick this box. The old term critical limb ischemia, one of the key aspects was rest pain, and rest pain had to be present for a patient to have critical limb ischemia. We know that actually, particularly in diabetic patients who've got significant peripheral neuropathy, they won't necessarily have pain as a consequence of their neuropathy, but nevertheless have tissue loss and arterial disease that would satisfy this as a definition. So what we mean is rest pain and or tissue loss for a minimum of 2 weeks duration in the presence of peripheral arterial disease. And that's deliberately a bit woolly. That might be that they're known to have peripheral arterial disease. It might be that they have other features of peripheral arterial disease. It might be that you can't feel pulses, or just that they have risk factors that are suggestive of peripheral arterial disease. So CLTI is a hot topic, and it's perhaps the biggest burden of our workload, certainly for inpatients. It makes up about 70 to 80% of our inpatient workload. It matters because we know that patients with chronic limb-threatening ischemia are at very high risk of ending up with a major limb amputation. But also these patients are a cohort of patients who are at very high risk of dying within the next 12 months. As you can see here, the evidence suggests that over 20% of these patients will either die or lose a limb within that first year. So prompt diagnosis is a key to improving both the survival of the limb in terms of revascularization, but also in terms of modifying those risk factors to ultimately prolong a patient's life. So how are you going to pick up the patients with CLTI? Well, actually, the vast majority of this is identifiable on the basis of history alone. The pain of ischemia is quite characteristic. It is unremitting. These patients have no relief from their pain, and they'll adopt all sorts of postures to try and get comfortable. The classic posture is hanging the leg out of the side of the bed, dangling it onto the floor. But alternatively, patients may say that they wake up every half an hour, and they get out of bed, or they wander downstairs or to another room because they find it more comfortable to have their legs hanging down. For patients who are bedbound and struggle to achieve that dependency of the limb, often they'll hold their knee in a fixed flexion because, again, that offers some relief. Patients often describe sleeping in chairs because, again, it's the only way they can get any relief. These patients are almost certainly going to have risk factors for peripheral arterial disease, as I've already outlined. And when you go on to examine these patients, there may be evidence of tissue loss. Remember, they don't have to have tissue loss. Pain alone is enough to achieve a diagnosis of CLTI. But they may have gangrene of a digit, or more extensively than that. There may be ulceration. And the ulcers typically are punched out in appearance. We're going to talk about venous ulcers later. And then we can compare a little bit with what the appearances look like. But the location of this ulceration is quite specific as well. So typically you tend to get ulceration over pressure points, often involving the digits, the medial or lateral malleoli, or very commonly on the heel. The other point to make is that these patients often have dilatation of the capillary bed, and that gives the foot an erythematous or sunset appearance. I'm not sure how well that projects, but hopefully you can see that there's a definite color difference between the 2 feet. And actually, it's tempting to say that the foot that you see on the right of the screen is the better perfused foot because it's pinker. Actually, that's not the case here. That's capillary bed dilatation, and that's because this is an ischemic, chronically ischemic foot. As a consequence of ischemia, you get all sorts of mediators released that cause maximal vasodilatation as the body does its best to try and improve perfusion. And one point that I really want to emphasize is that actually a lot of the patients that we see with CLTI are given course after course after course of antibiotic that achieves nothing. I have to say, it's almost the majority of patients who will describe having 3 or 4 courses of antibiotics before ultimately they're referred to us. So it's really important to say that cellulitis causes warmth of tissue. If it's not there and the foot is cold, then this is not cellulitis. A cold red foot is almost always pointing to chronic limb-threatening ischemia. So it's perhaps just a helpful distinction to make. So how are we doing in Nottinghamshire with regards to this? Well, unfortunately, we have one of the highest amputation rates in the country. And we're probably sitting about 10% above the national average when you start looking at the figures in more detail. Why is that? Well, I don't think there's any single factor. I think it's really a pathway-wide problem. I think sometimes these patients are referred late. Traditionally, we've been slow to assess these patients, and also we know that there's significant delays from secondary care in terms of being able to intervene on these patients. And all of those contribute ultimately to the higher than average amputation rate. Amputations obviously have very significant implications for the whole ICB, both in terms of additional social care input, but also these patients, as I've already said, become deconditioned, have a high mortality. Nationally, this is recognised as a problem, and this year, for the first time, a sequin was introduced to try to encapsulate the Vascular Society's guidelines for the management of peripheral arterial disease, or specifically chronic limb-threatening ischemia. So our target from the point of referral to review is 48 hours. And I can say categorically we don't yet achieve that for the majority of patients unless they're admitted via our surgical triage unit. In addition, there are pretty tight targets for referral to some form of revascularization, be that as an outpatient up to 2 weeks, or if the patient is admitted, then they should be revascularized within 5 days. The key really is that from a primary care perspective or community perspective, what we would ask you to do is to try and recognise and refer these patients as promptly as possible. How are we going to improve from our end? Well, from the end of this month, we're going to start daily hot clinics that will essentially enable us to review these patients in an outpatient setting the same day or next day, in reality, after the referral is made. It'll be consultant delivered care with a nurse practitioner leading the sort of coordination of the service, and the patients will have a kind of a one-stop pathway with scanning in the clinic, additional tests as required, and then we will arrange intervention as needed from there. So if you suspect a patient has chronic limb-threatening ischemia, then, as you would already do, please phone the vascular registrar on call, and I've included the phone number for those of you that don't already have it, because sometimes it's useful just to be able to jot that down or stick it on a post-it somewhere. But also, we would ask you to complete the electronic referral forms as you would for any other outpatient referral. But it is really helpful if you can both, given that we only have 48 hours to arrange an appointment for this patient, it'd be really helpful if you could do both of those steps. And that process will start from the end of this month, as I say, it's Monday the 28th of November. So that's the first half, if you like, talking particularly about peripheral arterial disease. And before I go on to talk about leg ulcers and venous leg ulcers in particular, does anyone have any particular questions, or is there anything from the chat that anyone has highlighted?
Yeah, thank you very much for that. It's quite informative. No, there isn't anything on the chat, but this could be a opportunity to perhaps for people to ask any questions about this topic. I mean, for me, it was quite interesting that the terminology has changed. And can I just ask about sequin? Is that something, because in primary care, I don't think I've come across this term. Is that some kind of targets that you have to meet, or can you clarify on that, please? Yeah,
so sequins are care quality indicators, I think.
Okay, yeah.
But they're set by NHS England, so they're nationally determined targets, and this year they don't, but actually in every year gone by they attract funding. So it's actually a penalty rather than a financial incentive. So if you fail to meet the targets of the sequin, then the trust will be penalised as a consequence of that. And in terms of the magnitude of that penalty, just as an example, the penalty to NUH, or a trust the size of NUH, would be about £1.3 million. So
Wow.
it's a significant chunk of funding for what, I mean, in terms of our service, we're a relatively small department in the context of the whole hospital, although we are one of the biggest vascular units or bigger vascular units in the country. So yes, that represents a significant chunk of funding, really.
Yeah, definitely. We do have some questions come through now. So do you recommend we start clopidogrel in primary care if we suspect peripheral vascular disease?
Yes, please. That should be sort of standard practice, and that's in line with NICE guidelines.
Yeah, I suppose that includes statin and just risk factor assessment and smoking and just general things. Yeah.
So anyone with peripheral arterial disease, be that asymptomatic or symptomatic, should be started on clopidogrel and high-dose statin. I suppose in
guidance, I guess, to correspond to. Yeah, brilliant. Yeah. Thank you. Is there anything else anybody wants to ask? Please do unmute yourself or put it in the chat box. I know we've been asked about a copy of slides. People always like that. So would that be okay?
Yeah, by all means, I'm happy to share the slides. Yeah. I think Denise has them already, actually. So,
yeah, I think she said that she was.
I'm happy for her to share those around.
Brilliant. I think that was quite useful as well, the registrar number. If anyone wants, I can put it in the chat box. But no, that's great. Thank you.
Okay. So I'll move on to talk a little bit about venous leg ulcers because they are incredibly common. What do we mean by an ulcer? Sometimes it's helpful just to start really basic. And in terms of certainly the National Wound Care Strategy's definition, this is any wound that's been present for more than 2 weeks. Now, it is debatable whether that truly it represents an ulcer. If someone drops something on their foot and it takes a bit longer than 2 weeks to heal, is that an ulcer, or is that just a sort of a wound that's not yet healed? It's open to debate, but nevertheless, that's the criteria that is used by the National Wound Care Strategy. Ulcers are very common, and certainly in the older population, about 2% of patients will have lower limb ulcers. The vast majority of these ulcers are due to underlying venous hypertension. And ulcers represent, or the management of ulcers, particularly in the community, represents a massive burden financially to the NHS.
I have got another question. I don't know if you want to take it now, or we can.
Yeah, by all means, yeah.
Yeah, so Philip has put, if a vascular patient is waiting for an amputation and is in constant pain despite analgesia and has a long wait for surgery, is there anything we can do as nurses, and can the surgery be expedited?
So, I mean, ultimately, if the decision's already been made that an amputation is necessary, then actually the only bridge, as you say, is analgesia. I think if there's a patient that is struggling with pain and the decision has already been made they need an amputation, then actually it's worth flagging that up with our service if you're thinking about a particular patient, because it may be that actually they need to be expedited on the waiting list. So if there's a particular patient in mind, then please let the secretaries know, and we can certainly look into that and look to expedite them.
That's also something that can be, you can contact the vascular CMP on call number, and we would look into that for you as well if you had a particular patient that you know about.
Brilliant, thank you. That's really helpful. So communicate essentially with the department.
Yeah.
Patient health. Thank you.
So thinking about venous hypertension, within the lower limb there and in the upper limb as well, there are two sets of veins. There's the deep venous system and the superficial venous system. In both venous systems, the drainage of blood is towards the heart. Obviously, that's northwards against the effect of gravity. To maintain flow against gravity, we rely on one-way valves. In a proportion of patients, those valves aren't working, or the mechanism to drive blood forward, which is the action of the calf muscle, is not working. As a consequence, you get high pressure within the venous system. And as I say, that can be because of incompetence of those valves. It can be obstruction of the venous system, so for example a DVT, or The other big aspect that we do see is patients who are fairly immobile and aren't walking. And the reason for that is movement of blood in veins. Obviously, veins are a low pressure system, and the movement of blood is very heavily reliant upon compression of the veins by the calf muscles when we walk. So if patients aren't walking, actually patients lose that pump mechanism, and therefore you get relative stasis of blood and the consequences of venous hypertension. In terms of classifications, people tend to use a variety of different classifications, but actually the most widely recognized is the SEEP classification. SEEP stands for the clinical features. The E stands for etiology. I'm afraid it's American, and therefore they drop the A off the front. A stands for anatomy, and the P stands for pathophysiology. But actually, the majority of the time, the most important aspect is the clinical grading. And for patients who've got either spider veins or uncomplicated varicose veins, and they don't warrant treatment within the NHS. So certainly C1, C2 and C3 disease wouldn't merit a referral to vascular surgery because they wouldn't satisfy the CCG criteria. With the exception of thrombophlebitis, which sits slightly outside of this. For patients who develop skin changes of venous hypertension, then those patients are at higher risk of ulceration, and certainly those patients would potentially benefit from consideration of intervention. I thought it was helpful to perhaps just briefly run through some of those skin changes because people may have heard the terms, but may not necessarily be terribly familiar with what they look like. Hemosiderosis is perhaps the commonest skin change that we see, and that refers to the brown pigmentation of the skin, typically around the ankles, but can be anywhere in the gaiter region. Again, the gaiter region is another term that people may or may not understand. Is a bit specific to vascular surgery. For those of you who are keen walkers, gaiters are waterproof equipment that essentially you strap onto your walking boots that extends from the level of the ankle to the level of the knee, and then when you're walking through long wet grass you don't get your trousers wet. So the gaiter region is between the ankle and the knee, and that's where the changes of venous hypertension most commonly manifest, simply because gravity means that the highest pressure within the venous system is at that level. What does lipodermatosclerosis look like? Well, you get this inverted champagne bottle appearance of the leg, and actually, essentially, you get fibrosis of the skin, again, just above the level of the ankle. The skin is very hard at that level, feels quite indurated, and if you run your finger along the side of the calf, you can feel a very definite step. So in edema, sometimes you get this gradual transition, but actually in lipodermatosclerosis, you can feel a physical step between the fibrotic zone and the normal tissue above that. Atrophy blanche is a term that describes the appearance of what looks like scarring. So again, it's a fibrotic skin change. Sometimes this represents healed ulceration. Actually, you don't have to have had ulceration to develop atrophy blanche, and sometimes it develops de novo, essentially because of the skin not quite breaking down, but the underlying tissues actually being necrotic and demonstrating that healing process with scarring. Varicose eczema, I'm not going to try and talk to a group of primary care clinicians about eczema because you will see it far more than we do, but you get the fairly classical appearance of eczema around the level of the ankles with ichthyosis and erythema. Often it's very itchy.
Sorry, just on that, we've had, can hemosiderosis be look purple? Well?
It can have a purplish tinge, yes, and it doesn't have to be brown. The vast majority of patients have brown discoloration. I'm not quite sure why some patients have slightly different colours, but it can be purple. The point being is that this is quite discrete though. So if it's diffusely purple, then you have to wonder whether it's truly hemosiderosis or whether there's a different process. But if you can see definite borders to it, then the discoloration may be hemosiderosis if it's purple, yeah.
Yeah, okay, so that was a question from the chat. And just in terms of greater area, are we talking about just medial aspect, or is it all of the between ankle?
It can be on the medial or the lateral aspects, or indeed anterior or posterior. So really the whole gaiter region, as I say, typically above the ankle, can extend slightly higher towards the knee. Okay,
brilliant, thank you.
So in terms of venous leg ulcers, again, this is something that I'm sure many of the people who are listening in will have seen many a time, but we're talking about ulcers that are superficial. The edges are often described as sloped, but really that's just to distinguish them from that punched out appearance of arterial ulcers. Venous ulcers are usually more superficial, although often we do see patients who have fairly advanced ulceration with exposed tendons, but that represents a minority of all venous ulcers. The ulceration may be quite sloughy. There's often a bed of granulation tissue, and these patients will often have some stigmata of venous hypertension as well. So, for example, in the photo you see, this is a very classical venous ulcer in a very classical location. And there's some hemosiderosis visible just above the area of ulceration. So again, in terms of leg ulcers, there is a sequin, and this time the sequin sits not with the hospital, but with the community nursing service. Again, this has had quite a significant impact on our service, which I'll talk about in a minute. But the National Wound Care Strategy has stipulated that patients with a leg ulcer should undergo a comprehensive assessment, and the criteria involved in that assessment are defined as part of the sequin. These patients should be in compression bandaging or wraps, depending on what compression therapy you use, as long as it applies at least 40 millimeters of mercury's worth of compression. The only exception to that, if there's evidence of underlying arterial compromise, and we'll talk about what that means in a second. The third aspect of the leg ulcer sequin is that these patients should be referred on to vascular surgery. And this represents quite a significant change in practice, because historically, only a small minority of leg ulcers referred to vascular surgery. We know that we saw perhaps 10% of all the leg ulcers that the community nursing team were managing. But the payment threshold for full payment for this sequin is 50%. So actually, that represents a 4- to 5-fold increase in the number of patients with leg ulcers that are likely to be referred on to secondary care. In terms of how you assess for arterial compromise, there's various different ways of doing that. Palpation of pulses using a handheld Doppler, measuring ABPIs, or toe pressure measurement. The problem with the first two is that they're pretty inaccurate, and actually they shouldn't really be used as an objective measure of arterial perfusion. So it can be helpful to feel pulses, but we also know that many people who are feeling pulses are actually just feeling their own digital pulses, and therefore they're pretty low sensitivity in terms of the reliability of that test. Doppler signal assessment, whether signals are monophasic, biphasic, or triphasic, again, that's a relatively subjective assessment and not terribly reliable. Ankle brachial pressure indices involve applying a blood pressure cuff to the arm and then measuring the blood pressure in the conventional way, and then comparing that with the blood pressure in the ankle. That's a fairly useful measure. However, a lot of patients will have a degree of incompressibility. And what I mean by that is that they develop calcification within the tunica media, and therefore actually when you inflate the blood pressure cuff, the wall of the vessel is so rigid that you can't actually get it to collapse. We also know that patients who've got leg ulcers tend not to like someone putting a blood pressure cuff immediately over the ulcer and then pumping it up, because that hurts. So often it's quite difficult to get a measurement of the ankle brachial pressure index in patients with leg ulcers. So what about toe pressure measurement? And increasingly this is our preferred measure of arterial assessment. You can see in the picture on the right an example of someone measuring a toe pressure. It's a pretty simple bit of kit, really. Essentially, you put a little sensor on the tip of the digit, and then you apply a blood pressure cuff just below that. Toe pressures can be measured either on the great toe or on the second toe. A slightly complicating factor in vascular surgery patients is often patients have lost those digits, in which case you can't measure toe pressure. But hopefully for most of the venous leg ulcers, it should be an option that's open. And we know that in patients who've got significant vessel calcification, actually you can get pretty reliable readings for toe pressures. So in patients who you can't measure an ABPI, often a toe pressure is recordable, and it gets around the problem of using a blood pressure cuff on an area that patients find very painful. The other point, certainly within the context of patients with chronic limb-threatening ischemia, is that the pattern of disease is changing. So particularly in diabetic patients, a significant burden of the arterial disease is not so much above the knee, but actually much of it's below the level of the knee and even below the level of the ankle. Increasingly, we're treating more and more distal disease, and therefore we need to have an assessment of perfusion that assesses the most distal point, and that's why toe pressures, again, are really helpful. There's pretty good evidence to support the fact that they are both sensitive and specific, and they're certainly more sensitive than an ABPI. There's ongoing work around comparing toe pressure measurement with other modalities, but I would suggest that it's a really helpful and pretty quick tool to assess distal perfusion. And ultimately, I would like to see toe pressures replace ABPI. It's also a lot quicker than an ABPI because you don't have to measure the blood pressure in the arm. Various work's been done around looking at what level of perfusion is required in order to achieve healing. And if you look at toe pressures, then really below a toe pressure of 55 millimeters of mercury, the chance of healing is substantially reduced. So the cutoff we would use is 60 millimeters of mercury, just because it's a round figure and it's easy. And so if a toe pressure is above 60 millimeters of mercury, that's adequate arterial perfusion. And if a toe pressure is below 60 millimeters of mercury, then at that point, it's worth considering onward referral to our service. The reason for that is that often these patients have mixed arterial and venous ulceration, and the first step in the management of those ulcers will be addressing the arterial side before then addressing the venous side. So coming on to the management of venous hypertension, again, what does that involve? Well, the mainstay, as we've already highlighted, is compression therapy in any of its various forms. Leg elevation is really important, and actually it's one of the simplest things that patients can do to reduce certainly the exudate from their wound and improve wound healing. We know that edema and the presence of edema is likely to slow wound healing. Paradoxically, whilst we want patients to elevate their legs, we also want them to stay really active. And the more walking that patients do, the better, and because that activates that calf muscle pump and helps to improve venous return. So what I say to patients is it's great to walk, and I would encourage you to walk, but whenever you're not walking, you have to get your leg up. So what we don't want them to do is stand for any prolonged periods of time. In terms of intervention, I'm going to talk a little bit more about intervention in a sec, but the majority of interventions that we undertake are for superficial venous disease. And remember, there's two venous systems, the deep and the superficial systems, and you have to think of them really in isolation. So we offer a range of treatments for superficial venous disease in line with NICE guidelines. Radiofrequency ablation is first-line therapy, with sclerotherapy being the second-line therapy. That's largely the consequence of a trial called the CLASP study, and that demonstrated that the most cost-effective intervention is radiofrequency ablation. The second most cost-effective intervention is foam sclerotherapy, even though it's less clinically effective. So there's a very heavily cost-influenced behind that decision, really. In terms of deep venous disease, there are some options for treating deep venous disease. They are very limited, though, and many of these patients aren't really suitable anatomically for deep venous intervention. So it's perhaps the hardest group of patients to treat, those who've had recurrent DVTs, because often there are no options to address the venous hypertension for those patients beyond conservative measures. As I say, radiofrequency ablation is the first-line therapy for superficial venous disease. It's done as a day case. The vast majority of patients are suitable for this under local anaesthetic. And we know that if you look at the sort of follow-ups, duplex scans at 6 months, about 83% of patients in the CLASP trial demonstrated that they'd had a good clinical result. Not everyone is suitable for this, and that's determined really by the depth of the vein, the caliber of the vein, and the relative tortuosity of the vein. It's also worth noting that often we'll do radiofrequency ablation in combination with other therapies such as phlebectomies or alternatively foam sclerotherapy. What does it involve? Well, simply involves putting a needle in the vein. Typically, we're treating the great saphenous vein, so the needle will be inserted around the level of the knee, and that's done under the assistance of ultrasound guidance. A catheter is then passed up through the vein to just below the level of the saphenofemoral junction, and that catheter has a heating element at the end of it. A series of injections are made down the thigh over the vein. Essentially, they will collapse the vein down and create a zone of fluid around the vein to stop adjacent structures being heated. And then the treatment itself involves heating that catheter internally, which burns the inside of the vein, and that causes it to collapse. Moving on to foam sclerotherapy. Again, this is done as a day case procedure. Patients will only have this under local anaesthetic. It doesn't require a general anaesthetic. As I've already alluded to, this is less clinically effective than radiofrequency ablation. It's also interestingly less clinically effective than open surgery. However, it's cheap. And given that, that's why it's second line as per the NICE guidelines. Again, what does it involve? Well, the causative varicosities are identified on ultrasound, and then a needle is introduced, and essentially foam is injected directly into the varicose veins. That causes a chemical reaction, and ultimately the veins will typically develop a kind of a thrombophlebitis type response, and then they should contract down. However, as I say, it's only about 55% effective, and therefore it's pretty common for patients to need more than one course of treatment. Nevertheless, pretty much all patients are suitable for this, and therefore it's not necessarily a bad treatment to give, albeit that it perhaps is less effective, but it's simple and cheap. So why has this leg ulcer sequin been introduced? Why should all these patients with leg ulcers be sent to vascular surgery for consideration of intervention? Well, there's two real trials that are, if you like, the reason behind that change in practice. The first of those trials is actually pretty old. It was from 2004. It's called the ESCAR trial. And that was a UK-based randomized controlled trial recruiting about 500 patients. And the two arms of the trial were to use compression therapy alone, or alternatively, compression therapy followed by open surgery. Back in the early 2000s, we didn't have radiofrequency ablation and foam wasn't widely used. So all of those patients only underwent some form of open varicose vein surgery. What that trial demonstrated was that actually at 12 months, you can more than halve the recurrence rate of ulcers. So the benefit in doing intervention of these patients is that, given that we know a significant proportion of these patients, by which I mean in the compression alone arm, about 50% will go on to develop re-ulceration. If we intervene, we can certainly substantially reduce the proportion that will develop further ulcers. That has a massive impact on the quality of life for patients, but also has a big impact on community nursing resources. The second trial is far more recent. It's called the Everest study. Again, was a UK-based randomized controlled trial. The difference here was that patients were treated in much the same way with compression therapy in one arm, and then in the other arm, compression therapy and early endovenous intervention. So this time, radiofrequency ablation was used. Some centres used foam as well. What this showed was that actually, if we intervene early on these patients, then the interval from referral to ulcer healing substantially reduces. And as you can see here, there's a significant reduction of 26 days, so about a 30% reduction in time to ulcer healing from intervention. So putting those studies together, the leg ulcer sequin demonstrate, or it sort of encapsulates that evidence that if you intervene, not only do you reduce the rate of recurrence, but you also improve ulcer healing. That's great for patients, and I think it's a really positive thing. However, it does have implications for the whole service, really. And we know that our number of referrals has substantially increased. We already have a substantial waiting time for varicose veins, and that's going to get worse as a consequence. And we're in the process of arguing with the commissioners to give us a bit more resource to be able to manage this big influx since the sequin was introduced in April. But ultimately, I think it's the right thing to do. It's just how do we manage that increased burden of work? So hopefully that's been a bit of a run through of both peripheral arterial disease and venous disease, highlighting some of the targets that we have to hit, some of the community nursing targets, and perhaps some of the things that we're doing as a service to try and meet that. Again, does anyone have any questions they'd like to pose?
That's great. Thank you very much for that. Yes, open to everybody if you've got any questions. Seems like you made it clear to everybody. It was really interesting, this toe pressure measurement. I'm just be interested in how many primary care nurses, etc., staff are using it. I mean, it'd be really helpful if you could put it in the chat box if that's something you're using. Because yeah, so Afshan has put, that was brilliant. Thank you so much. I think we had a comment before as well. Philip said it's fantastic. Thank you so much. So lots of people really liked it. But yeah, it's interesting. I mean, so somebody has, but Emma has got an answer. To clarify, when should we refer leg ulcers to vascular, please?
So essentially, according to the National Wound Care Strategy, that any patient with a leg ulcer essentially should be referred to vascular surgery. So any wound on the leg that's been present for more than 2 weeks needs to undergo a comprehensive assessment in line with the National Wound Care Strategy, and then at least 50% of those ulcers should be referred on. I guess the ones to perhaps not refer, patients who are bedbound, we're perhaps less likely to offer those intervention. There may be patients who don't want to be referred, and that's why it's set at 50% to allow a little bit of leeway, but actually the vast majority of these patients are going to need to be sent to us. And we know that actually, having spoken to the community nursing teams, that as they're starting to implement the sequin, about 75% of all the leg ulcers they're seeing are starting to be referred on.
I mean, that's quite a lot for you to deal with, I guess. I think
I
that's
know.
I think Emma's commented on that as well. It seems very unrealistic to refer everybody.
Yeah, and I think it's tricky, because I think the evidence does support that. However, there isn't the resource currently there to meet that. So
Yeah.
but I think that's sort of pretty typical of the way healthcare runs, really.
Yeah.
We identify what's good, and then we recognise that we don't do it, but we don't necessarily meet that with adequate resources to match. So.
Yeah, exactly. So it's the guidance is one thing, and then how practically, how possible it is. I mean, I think a lot of people have said that they're still using ABPI in the community, but I think there are some tissue viability nurses and other people might use. I don't know. I think Pauline, sorry, did you want to say something?
As far as I know, only the tissue viability team are trained to do toe pressures, leg ulcer clinic. As far as I know, I don't know any of the district nurses who know how to do toe pressures. And in fact, it's often the APs who do the ABPIs with the Doppler machine. That's one of my jobs.
Yeah, okay, thank you. Yeah, so I think a lot of people have put that, same ABPI, but maybe tissue viability do perform toe pressures. Now, I think Karen's put, we use waveforms alongside a detailed history, but may need to consider toe pressures. And then there's a question from Ruby: how soon can we refer for claudication?
So, I mean, there's no right and wrong answer to that, really. I think if a patient hasn't already had their medical management optimized, then there's very little point in referring them to us, because we're just going to say, well, here's some clopidogrel and some atorvastatin and stop smoking, and we'll phone you again in 6 months' time to see what's happening, sort of thing. So we're not going to do very much at all with those patients other than just give them that advice. If I'm honest, I don't think there's any value in referring anybody with claudication who's still smoking, because again, we're not going to offer them any intervention, so we're not going to offer them anything above what you could already offer within the kind of primary care setting. So really, I think it's a case of optimize the medical management and encourage the patients to mobilize. But if they're still struggling, particularly in those patients, I guess, where it's lifestyle limiting, and by lifestyle limiting, really, I'm talking about less than 100 meters. Sometimes we get referred patients who can only walk half a mile, and you sort of think, well, yeah, we know that a proportion of patients that undergo an angioplasty will ultimately have a complication that results in an amputation. So converting someone who can walk half a mile to someone who is wheelchair bound is a disaster, and therefore they might have to just learn to live with half a mile. But there are some patients who can only walk 20 meters, and actually, there are some people who, I can think of a postman who was referred who could only walk 200 meters, but actually he was young and couldn't do his job, and that for him was a disaster. So after talking about the risks, yeah, we went on and intervened in him. So it depends a little bit on the patient, really. But really, we're talking about shorter distances. If patients can walk a decent distance, sometimes they're going to have to do lifestyle modification and essentially learn to modify their activities to a certain extent. Yeah.
Brilliant. That's very helpful. Thank you very much. Are there any other questions before we move on?
I would just add, really, in terms of toe pressures, if there's an appetite to learn a bit more about toe pressures, or if that's something that the community teams are interested, then certainly we would be happy to support and provide a little bit of education around that.
Yeah, because it sounds like ABPI, I think everybody's, from my experience, is too scared as well to undergo the whole process, quite time consuming, and now you're saying patients are not comfortable. So if there's a better tool available, then yeah, definitely.
Yeah, and I think the benefit of toe pressures is it is pretty quick. It takes perhaps 2 minutes to do. In terms of the kit, yes, you need a toe pressure kit. They cost about £1,500. which in the grand scheme of things isn't a huge amount of money. Yes, okay, it's an additional cost. But certainly we talked to the community podiatry team recently, and sort of off the back of that, they were able to get funding for at least half a dozen toe pressure machines, and they're now fairly routinely using toe pressure machines. And I think that, again, that's sort of changed their service. They find it a lot easier. It's pretty easy to pick up, really.
Thanks a lot, thank you. Okay,